Our last two topics we're going to talk about are cardiac output and stroke volume and heart rate. Those kind of go together. And then we're going to talk about a few homeostatic imbalances. Okay. So cardiac output is a readout that clinicians use to establish the health of the heart. Okay. So what cardiac output is the volume of blood pumped by each ventricle in 1 minute. And what it's defined by is, so essentially our CO here is cardiac output, equals our heart rate times something called stroke volume. Okay. So again, this is used clinically to assess a person, for example, a patient who's in heart failure, okay, would have a diminished cardiac output. Okay. So typically when you think about heart rate, okay, it's the number of beats per minute. That's easy. And stroke volume is the volume of blood pumped out by one ventricle with each beat. Okay? One ventricle with each beat. We're going to talk more about that here in a few minutes. So on average, the cardiac output of an individual is about 5.25 liters per minute. Okay? So if you increase heart rate, you increase cardiac output. If you increased stroke volume, you increase cardiac output. Okay, and that makes sense, right? So if we have up here, right, cardiac output equals heart rate times stroke volume, if I increase this, I subsequently increase this. If I increase this, I increase that. Okay, so you increase one of these, you're going to increase cardiac output. So on average, the maximum cardiac output, okay, that one can achieve is 4 to 5 times their resting cardiac output. And that's typically in non-athletic people because their heart efficiency is just not as good as athletic people. People who are fit and in shape and athletic, they can sometimes increase their cardiac output by 7 times their resting cardiac output. Okay, so I want to talk a little bit more about stroke volume. Okay. Again, if we go back and look at the definition, the volume of blood pumped out by one ventricle with each beat. Okay. So stroke volume is something called end diastolic volume minus end systolic volume. Now you might be like, oh my God, what is, like, this is so complicated. Okay, I want you to take a minute and I want you to think about what these words say. Okay, so we have EDV, end diastolic. So what's diastolic? Relaxation. Okay, so at the end, and I'm just going to draw one ventricle. Okay, at the end of relaxation, what is the volume in our ventricle? Okay, think about that, right? So if we're at the end of diastole, that means that we're about to start contraction, which means, okay, which means our ventricle is full of blood. Okay, end diastolic, end of relaxation volume. Okay, and systolic volume means the end of contraction volume, right? So essentially, after the heart is contracted, what is left in the heart? Okay. Okay. So we just subtract these two things from each other and we get our stroke volume. Okay? Okay. Now, there's 3 things that affect stroke volume: preload, contractility, and afterload. Let's look at these 3 really quick. So, preload is the degree of stretch a cardiac muscle cell, stretch of cardiac muscle cells before they contract. Okay, so when we think about preload, typically the most important factor for stretching a cardiac muscle is venous return, the amount of return coming to the heart. Okay, so if you increase exercise, so if you exercise, right, you're increasing flow back to the heart. If you slow heart rate, right, you decrease the number of times you empty those chambers in a minute, you're also going to increase venous return, i.e. preload. Okay? So think of it this way. If you have a rubber band, right? Well, let me come back to that. Okay. Our second factor is contractility. Okay. So this is the contractile strength at a given muscle length, independent of muscle stretch. Okay. And end diastolic volume. Okay. An afterload is the pressure the ventricles must overcome to eject the blood. Now I want to talk just a little bit about this notion of afterload, because clinically it's typically your biggest, has your biggest impact on stroke volume, because it's typically the one that is most often seen. Okay, so let's look at this. I'm going to go back a slide. I'm going to change my color to, okay, so actually let me do this really quick. Okay, so afterload, think about it this way. Okay, so this ventricle has to pump blood out of that chamber through a vessel, right? Oh shoot, just kidding. So we'll put the vessel over here as well, right? So that blood has to be pumped out. Okay, and what we end with at the end is that. Okay, now, and again, afterload, because remember, this is a tube structure, so there's a pressure being applied back on that blood. Okay, that pressure, that back pressure that's going against the ejection pressure is what we call afterload. Okay, now, clinically, okay, patients with atherosclerosis or hypertension, okay, what happens is we go from a diameter like this, and this is exaggerating, to a diameter like that, right? Now that blood has to come out and go through a much smaller diameter. And a smaller diameter means we have greater afterload. So if we decrease, if we increase afterload, okay, and this can be due to a decreased diameter, which would be hypertension. It can be through atherosclerosis. Okay. If we increase afterload, what happens is the amount of blood, because remember, the heart still has the same time to eject. Okay. But imagine, okay, so imagine taking a balloon that has a hose on the top of it, on the mouth part, right? And you squeeze that balloon and a whole bunch of water shoots out that hose. You have a second to squeeze out as much water as you can. Okay? Now you have a second to squeeze as much water out of a straw, a coffee straw. Let's make it a coffee straw. Okay? You're going to get a lot less water out. So what you're going to end up with at the end of systole, okay, is a greater volume here. So what that means is if you increase afterload, you increase end systolic volume, okay, which ultimately means you decrease stroke volume. Now you might be like, whoa, what do you mean you decrease that? Let's look at this mathematically. If stroke volume equals end diastolic volume minus end systolic volume, okay? If this is 50, so this is normal, okay? If this is 50 and this is 5, okay, this equals 45, okay? If under abnormal, which is in this case, if we increase afterload, okay, we still deposit the same amount of blood, but now the amount that remains is more, so our stroke volume decreases. Isn't that exciting? Okay, so again, that's how afterload really ultimately affects our end systolic volume reducing. So if you increase afterload, you decrease stroke volume because you've increased ESV. Okay. So the autonomic nervous system, in terms of going back, we talked briefly about it when talking about it touching or affecting the SA node and the AV node, okay, or the SA node and how it targets or increases and decreases through the cardiac acceleratory center. This just elaborates on that a little bit more, okay, how that nervous system regulation occurs, okay. So emotional and physical stressors can activate that sympathetic nervous system. It releases norepinephrine, and that norepinephrine causes that pacemaker to fire more rapidly. We increase contractility, we increase heart rate, okay? On the opposite side of that, we have the parasympathetic system, okay? It releases acetylcholine as opposed to norepinephrine. And what that acetylcholine does is it actually hyperpolarizes the pacemaker population. So normally, under normal circumstances, I hope I didn't change this, right? So normally we have something that looks like this, and it goes up and goes like that, and kind of goes like that, right? Okay. So what acetylcholine does, and I'll make acetylcholine my black one, okay? So what acetylcholine does is it causes a hyperpolarization, so it takes longer to reach that threshold, and it goes up and comes down, right? So we hyperpolarize, it just takes longer. So what that does is it spreads out our heart rate, okay? Typically doesn't have an effect on contractility, okay? And again, heart at rest exhibits something called vagal tone, and this is where the parasympathetic kind of has a brake on the sympathetic nervous system, preventing that heart rate from increasing. So these are all the factors that can essentially impact our cardiac output, okay? And we talked about these kind of already, right? So we talked about things that affect venous return briefly. We have exercise, we increase ventricular filling time. Those will both increase venous return, okay? So that means venous return, that's EDV, right? We increase EDV, our preload, not our afterload, and we increase stroke volume, okay? We have chemicals in our body, epinephrine, right? We just talked about epinephrine and norepinephrine on the previous slide, but essentially epinephrine, okay? Increases contractility, decreases our end systolic volume, okay? Because we have more spring, we have more rubber band spring, okay? So we can contract harder, okay? That will increase stroke volume. And then we have central nervous outputs. So responses to exercise or fight and flight response. We have a decrease in blood pressure. These will both trigger sympathetic and parasympathetic. Okay, so if we decrease parasympathetic, we increase sympathetic, we increase heart rate. Sympathetic can also affect contractility, which increases stroke volume and ultimately leads to increased cardiac output. Crazy how it all comes together. Okay. Now there's also chemical regulation of heart rate. So again, epinephrine from the adrenal medulla can increase heart rate and contractility. Thyroxine, which is produced by the thyroid gland, increases heart rate. It enhances the effect of epinephrine and norepinephrine. The heart is extremely sensitive to ionic concentrations. So we have to make sure that we maintain proper concentrations of ions around cardiac cells. For example, if you have hypocalcemia, a decrease in calcium, this will depress the heart. If you have hypercalcemia, you'll increase heart rate and contractility. If you have hyperkalemia, too much potassium, this alters the electrical activity. You can have a heart block and cardiac arrest. Hypokalemia, again, so the heart is super sensitive specifically to potassium. Hypokalemia leads to feeble heartbeat and can lead to arrhythmias. So again, the heart is super sensitive to potassium, so we have to keep that into a very, very narrow range. Other factors that will influence heart rate, things such as age. A fetus has a faster heart rate than an adult does. Gender, women tend to have a little bit faster heart rate than women. Exercise obviously will increase your heart rate. If you go out and exercise, your heart rate increases to accommodate the oxygen and the things that the body needs. And body temperature. Body temperature can also increase a heart rate as well. So the last few slides look at homeostatic imbalances, mainly terminology. So tachycardia is an abnormally fast heart rate, typically indicated by over 100 beats per minute. If that is sustained, that can lead actually to fibrillation. Bradycardia is basically a heart rate slower than 60 beats per minute. Typically, This is actually desirable. So endurance athletes have typically a low heart rate, and that's because their heart has just become more efficient at pumping blood. In a non-athlete, it's not a good thing because it typically means that the body isn't being able to get enough blood circulation to the body. Congestive heart failure, CHF, is a progressive condition. This occurs in patients where cardiac output is so low that the blood circulation is inadequate to meet the tissue's needs. So the tissues start to become damaged. Typically, cardiac or congestive heart failure reflects a weakened myocardium that's caused by either atherosclerosis in the coronaries, okay, so a clogged blockage in the coronaries, persistent high blood pressure, multiple multiple myocardial infarcts, as well as dilated cardiomyopathies or DCMs. Okay. Your book doesn't really talk about this system down here on the bottom, but typically what you'll see presentation-wise in a patient who is in congestive heart failure, if that failure is on the left side, so if the left side of their heart has failed, okay, they typically present with pulmonary congestion. And that is because as that blood comes from the lungs into the left atrium, right, the left ventricle can't pump it out effectively. So you can almost get like a backlog of fluid into the lungs. And typically you can hear that, or that pulmonary. They try to address the pulmonary issues in patients who have left side failure. Right side failure results in what we call peripheral congestion. And that's because as the blood's coming up from the body into the right side, okay, the right side just can't get it to the lungs, so you get a backlog into the body. And those patients tend to have swelling in their feet, swelling in their extremities, especially their lower legs. And that's because the blood pools in the body's organs. Failure of either side can result in weakening of the other side, okay? So what they do with these patients in congestive heart failure, they typically treat with some type of diuretic to remove the fluid, the excess fluid. They reduce afterload, so they try to treat with hypertension. They try to deal with any atherosclerotic plaques, okay? And then they will also, if the patient is put on a heart transplant list, they will insert a device known as some of them are called LVADs, some of them are called, this here is a picture of an LVAD. It's called a left ventricle assistant device. And what happens is this external pump here, okay, becomes the left ventricle. Okay, and they're the coolest systems in the world, but they're the scariest systems in the world. So my dad had one of these put in. Unfortunately, he passed before he made it to transplant. But anyways, he had left side failure. They put an LVAD in, and there's a wire. It comes out of the skin, right? And he had this pump, external pump that sat here, and that external pump was then connected to a battery pack. Okay, now at night, they take this battery pack out so it can charge, and you hook up to a wall outlet, okay? So for that short period of time when you're transferring from the battery pack to the wall, you essentially are stopping the left side, because the left side is no longer working, right? This is the left side. If you remove the battery, no left side anymore. So that was always like something that freaked my mom out. She was always like super freaked out by the fact that she was going to kill him. She didn't. But she was always worried about that. But these are nice. It's a nice mechanism to allow someone to extend their life to be able to get that heart transplant. Okay, so that's all we have for chapter 18. Any questions? Make sure you guys are emailing me or texting me with any questions you might have.